The following podcast is part of a certified educational activity titled From Wheals to Wellness, Transforming Chronic Spontaneous Urticaria Care with Emerging Solutions. Access the entire activity and complete the post-test at peerview.com/DNY860. Downloadable slides and practice aids are also available.
Hello, I'm Michael Manning, President of Allergy, Asthma, and Immunology Associates in Scottsdale, Arizona. I want to thank you for joining this unique case-based educational activity on diagnosing and managing chronic spontaneous urticaria. The goals of the program today are to improve knowledge of key biomarkers used in diagnosis and assessment of CSU, or chronic spontaneous urticaria, equip you with the latest evidence surrounding emerging therapies for CSU, and also provide guidance on collaborating to develop a patient-centered care plan. So to start with, we want to kind of look at the prevalence and duration of CSU, or chronic spontaneous urticaria. The prevalence is anywhere between 1 and 5% of the general population, so it is something you will see frequently. Women tend to be twice as likely as men to have CSU, and though it can occur at any point in someone's life, it's most common between the ages of 30 and 50 years. The duration is very variable. Generally, it lasts 1 to 5 years, but can really last for decades. With chronic spontaneous urticaria, it's mainly having hives, but every now and then people will also have angioedema. And those who develop angioedema tend to experience longer-lasting symptoms. And in the diagram, you can see that about 60% will have hives only. Around 40% have hives and swelling, and some patients will have swelling only. And these can be a little bit of a challenge from a diagnostic standpoint. The other issue with chronic spontaneous urticaria is there is a significant burden of this disease. And in this slide, we look at all those different burdens. From embarrassment, breaking out and having hives all over the place, to it leading to difficulties with just activities of daily living, going to work, going to school, missing a meeting because you're swollen and are broken out and you don't want to go. Significant sleep disturbances occur with chronic spontaneous urticaria, really from the itch. It's waking people up at night. This can lead to social isolation. And I think one of the biggest things we see, and especially I see in the office, is there's a lot of stress and anxiety and even depression. The CSU patient is the one person that comes in, sits down on the table, and will cry. There are significant unmet needs in chronic spontaneous urticaria. Initially, there's a delay in diagnosis, and this is multifactorial. The average time from symptom onset to diagnosis can be up to 2 years. And that may be because patients are self-treating. They're going to the pharmacy and getting medicines over the counter. They're listening to their friends and family members before they see a physician. And by the time they see a physician, many times they may have a break in their urticaria for a few days, and either they forget to ask about it, or it comes back and says, well, let's wait and see if it happens again. It's a very complex diagnosis to look into. It's also refractory to standard therapy. So standard therapy is second-generation antihistamines, so these don't always work at standard doses. Then there's second levels of treatment going to now omalizumab, and we've got a couple of other options at this point, and newer medicines that are being studied. And the last thing is it's hard to control it. Even at high doses of standard therapy, about 40 to 45% of the patients respond to these doses of antihistamines. The rest don't. So let's look at providing a timely diagnosis and an accurate assessment of CSU. So this is looking at a patient, John. He's a 35-year-old gentleman who works as a long-distance truck driver. He presents with intermittent pruritic wheals appearing for the past 10 weeks. So he qualifies for chronic spontaneous urticaria. It's been longer than 6 weeks. His wheals last less than 24 hours and do not seem to be linked to changes in diet, medications, or other environmental factors. This is also consistent with urticaria because they tend to last for less than 24 hours. He reports difficulty sleeping and has significant daytime drowsiness, and this impacts his work as a truck driver. This could be from medications he's taking and also the lack of sleep due to the symptoms themselves. He's never had a diagnosis for these symptoms. He was seen by his primary care physician about the issue and is advised to take over-the-counter diphenhydramine. He's been using 25 milligrams every 4 to 6 hours for flares and itching. This has only been minimally effective. He messaged his PCP about ongoing symptoms and was told to switch to loratadine 10 milligrams daily. He reports that this therapy is only mildly effective. So what do we want to do with all chronic spontaneous urticaria patients? And this slide kind of outlines that. You know, there's questions, there's a good physical examination. We may look at some testing, and then it's really, is the urticaria under control, the UCT? We want to confirm the diagnosis, so rule out other potential problems in the differential diagnosis. We want to look for causes, and so now there's things we look at which look at indicators for CSU because it's really an autoimmune issue, and there's a couple of types of autoimmunity. There's type 1, which is autoallergic autoimmunity, and then autoimmunity, which is type 2B, which is typically driven by IgG antibodies. We want to look for other cofactors. Are there triggers that these patients notice? Is it worse with heat? Is it worse with activity? Can it be worse with certain physical aspects and trauma to the skin, pressure on the skin, let's say? Are there other comorbidities? We want to check for inducible urticaria. Can they ride on their skin? Again, is there pressure urticaria, vibratory urticaria? They use a device that vibrates their hands and their hands break out or swell. Is there a history of autoimmunity? And do they have other mental health issues that may be going on, either prior to the onset of urticaria, or is the urticaria leading to some of those mental health activities? Are there consequences to their symptoms? Is it affecting their sleep? Is it leading to distress? Is it affecting their work and school life, sexual health, social performances? And also, are there components that we can look at? We can look for potential biomarkers and predictors for treatment response. And we're getting better at identifying some of these things to say, well, we understand why you didn't respond to medication X, Y, or Z. We also then want to monitor the course. Once we start them on treatment, what's the activity of the urticaria? You can look at CSU activity, what's its impact on their life, and are they under control? So here's an algorithm looking at chronic urticaria, and you can see at the top of it, there's Wheals or the urticaria, there's the angioedema component, there's a little bit of an overlap. So looking at this, if there's purely angioedema only, easy question, are they on an ACE inhibitor? If not, is this hereditary angioedema or acquired angioedema? And some of that depends on age, and you can kind of go down through that algorithm, and either they've got ACE-induced angioedema, they've got HAE types 1, 2, or 3, or this lands in the role of it's truly, in the realm of chronic spontaneous urticaria. So if they've got Wheals only, are there other symptoms? Do they have unexplained fevers, joint or bone pain? Or do they have a lot of malaise? When you look at that, if they do, you may want to think about an autoinflammatory disease. If they don't, do the Wheals last longer than 24 hours? And they can really go to 36 hours or so, but if somebody says, yeah, that lesion lasts for 2 or 3 or 4 days, that's not hives, then we want to think about things like vasculitis. Have they had a biopsy? If those Wheals are less than 24 hours, is there inducible? And then you can see down the road, it goes into chronic spontaneous urticaria. You can look at urticaria vasculitis or other acquired or hereditary autoinflammatory diseases. And at the very bottom of the slide, you can see the different mediators that will lead to this. So bradykinin is working in hereditary angioedema and ACE-induced inhibitor angioedema. When you're looking at just, chronic spontaneous urticaria or even inducible urticaria, it's histamine and other mast cell mediators. So we'll say histaminergic urticaria or angioedema or mast cell mediated. And then interleukins are looking more at the autoinflammatory disease. So what are some of the recommendations? So we want to assess patients with CSU for underlying causes by asking the relevant questions I've kind of talked about, and also using specific tests as indicated in what's available. If you look at the guidelines, there's not a ton of testing that you start out with initially, but it's really looking at a CBC, markers of inflammation, looking at thyroid function, and also liver functions, looking for evidence of maybe a low-grade hepatitis or infection. So if you could measure total IgE now is helpful. You can look at anti-thyroid peroxidase antibodies, anti-TPO, if available. You can look into basophil histamine release tests also, and that can help tell you a little bit about that type 1 and type 2B auto and inflammatory conditions. So when we look at the different comorbidities associated with CSU, again, Hashimoto's thyroiditis is one of the first things that always comes up, whether it's cause and effect or just associated, is up for some discussion. Tends to be more with female patients and a positive family history with autoimmune disease. Look for signs and symptoms of hypothyroidism or hyperthyroidism, and some patients come in already with that diagnosis. If not, you can look at, look for physical findings that may be suggestive of that, and also look at the appropriate laboratory tests. We do want to talk about mental health with these individuals. Like I say, these are the people that come in and cry because they've not been taken seriously. It's been bothering them for 2 or 3 years. Their life is a wreck. Do we need to get them to a mental health specialist? There are tools to look into mental health and diagnose your mental health also if you want to use that in the office. And also then chronic inducible urticaria. Do they have dermographism? You can do that in the office and scratch their skin while you're initiating the exam, talking to them and see if it comes up and if they're inducible. Doesn't mean they don't have chronic spontaneous urticaria. They may also have an inducible component, or are they only inducible? The only time they have hives is if they traumatize their skin. Well, looking at the different components, and like I say, there's ways we can now look into this and kind of predict who's going to respond to certain medications and who may have a longer lasting disease, etc. So this slide looks at that, the different parameters. So at the top, long disease duration. So these people may have elevated IgG, anti-TPO antibodies. They've got high CSU activity and severity. We'll look into what goes into the chronic spontaneous urticaria score. And so the higher the scores, the more likely they're going to have longer duration of disease. Higher CSU activity is seen in individuals with elevated CRPs, elevated mean platelet volume, elevated IL-6. If you want to measure some of this stuff, a lot of this is kind of research driven. If they've had if they're going to have a poor response to treatment with second generation antihistamines, they may have a high D-dimer, a higher UAS score, high CRP. They've been on previous corticosteroid treatment, and low blood basophil and eosinophil counts. Easy to get an eosinophil count. How about a poor response to omalizumab? So that was our go-to. When somebody didn't respond to high-dose antihistamines, we automatically went to omalizumab, but not everybody responds. We wouldn't really do lab work prior to starting omalizumab, but we find that if they've got a low total IgE, they're more likely not to respond to omalizumab. And you can see the other tests that are also predictors of poor response to omalizumab. And then who would be a good response to, say, cyclosporin? That's kind of the step after omalizumab. They may have total low IgE and a positive basophil histamine releasing assay. So I've mentioned the UAS, Urticaria Activity Score, and this is the components of it. If you're not familiar with it, if you've not done studies in chronic spontaneous urticaria, that's really when you're going to use this. So there's two components for the UAS score, and it's UAS 7. You average it over 7 days. First is Wheals, and you can see it's graded from 0 to 3. 0, they have no wheals. 1, less than 20 wheals in 24 hours. Moderate, 20 to 50 hives in 24 hours, and intense, greater than 50. So it does take some counting. You look at the itch component, none, 0, mild. It's present but not annoying or troublesome. Moderate, it's troublesome, but doesn't interfere with daily activity or sleep. If it's waking them up at night, they're scratching and itching, that puts them in the level of 3. So you add the wheel number, say if it's a 2, and you add it to the itch score, a 3, daily, so that's 5. You multiply it by the 7 days and it comes up with a score. So the score is anywhere from 0 to 42. The highest daily score you can have is 6, and the highest UAS 7 score, the weekly score, is 42. So going back to John, again, he's had intermittent pruritic wheals for the past 10 weeks. His symptoms last less than 24 hours, or the wheals last less than 24 hours. So I described to patients, is it like bubbling water? It's just always moving, coming up and going away, right? Some of the biggest concerns are daytime sleepiness that is impacting his work. Again, it could be from sleep deprivation because of the disease and also the diphenhydramine he's been taking. And he's had little success with those. So looking at this, how would you navigate John's diagnostic workup? I mean, would you test for any specific biomarkers to rule in or out CSU? Some of the next steps would be to try another second-generation antihistamine. You could add an H2 receptor antagonist. There's data out that looks at H2s can be helpful in this. And when would you follow up, and how would you monitor for efficacy? So based on John's response, we want to start looking at ways to assess BTK inhibitors in CSU. It's a new area of research and focus in this chronic condition. So in John, we did some lab work. We kind of did those basic labs. His CBC was normal, sed rate was normal, thyroid studies were normal, LFTs were normal, which is not uncommon with this. Lots of times you don't need to do the test because if they just saw their primary care physician 6 months ago and they had a big workup, I'm sure all those were done. He was started on fexofenadine, so switched off from the diphenhydramine, started on fexofenadine 180 milligrams daily, was to return to clinic in 4 weeks for further assessment. So looking at this, if fexofenadine's ineffective, which treatment strategies best align with the most recent evidence and guidelines for the next step? And there's some good evidence for some of this. And would you, again, add on an H2 receptor antagonist for John? Well, when you look at the international guidelines, and U.S. guidelines are aligning with the international guidelines on treatment of chronic spontaneous urticaria, the guidelines really state you start with a standard dose of a second-generation antihistamine, and if needed, increase that dose. It really recommends against mixing and matching. Sometimes you have to if somebody just can't tolerate it. But you take that antihistamine, whether it's loratadine, fexofenadine, or cetirizine, levocetirizine, start it once a day. If there's no impact, you go all the way up to 4 times the standard daily dose. You can look and say, I'm going to reassess them every 2 to 4 weeks or earlier if they're having a really bad time with this. And if you get up to 4 times the standard dose and you're just not seeing any benefit, the guidelines really say move on from the standard second generation H1 antihistamine and add omalizumab at that point. Again, you want to wait about 6 months for control. When you look at the studies on omalizumab, a lot of patients will have, rapid benefit, early benefit, but you don't want to give up too early in that. If they are not doing well with their second-generation high-dose antihistamine and omalizumab, really the next step in the guidelines is moving on to cyclosporin. And that can be very effective in those omalizumab failures. So the treatment response to antihistamines, like I said, about 50% of the people really don't see great response to typical high-dose antihistamines. They remain uncontrolled, and we really don't have a whole lot of options. Like I said, we've got omalizumab, you got cyclosporin following that. There's a new agent that just got approved here recently, but additional safe and effective alternative treatments are options that are needed, and that's where the investigation and science is going. So mast cells and basophils, activation of these cells really is what releases the histamine and other cytokine mediators that lead to the dermal inflammation and the symptoms you get, the whealing, the swelling, and the itching. And this is a diagram on there. And you can see the mast cell and the basophil. And there's different triggers for these cells, triggers that bind to IgE antibodies already on the mast cell bound to the high-affinity IgE receptor. There's IgG antibodies that recognize the high-affinity receptor. There's KIT receptors. There's Siglec-8 areas you can look at. And inside the cells on all these, you can see that BTK, the Bruton tyrosine kinase, is in there. And it's downstream from all those triggers. So whatever trigger you're looking at, whether it's cross-linking IgE, acting on the high-affinity receptor itself, looking at KIT or Siglec-8, BTK is downstream from that and so is central to the activation of these mast cells and basophils releasing their mediators. So looking at the approved and investigational systemic therapies for chronic urticaria. So the first product that was approved back in 2014 was omalizumab. It reduces free IgE levels, which also leads to reduction in high-affinity IgE receptor expression, part of its benefit and effectiveness. Dupilumab was just recently approved in April of 2025. It targets the IL-4R alpha receptor, so it inhibits IL-4 and IL-13 signaling. It also reduces IgE levels in atopic individuals. We've also got 2 BTK inhibitors you can see on this slide, remibrutinib and rilzabrutinib. Remibrutinib is in phase 3 development. They're in phase 3 studies. The other is in phase 2 studies. There's an anti-KIT receptor inhibitor. It's in phase 3 studies. There's also an anti-c-KIT inhibitor in phase 2. Another inhibitor, EV0756, is in phase 2. You've got a JAK1 inhibitor, which is in phase 2. Wild-type KIT inhibitor, which is in proof of concept study at this point. So looking at the agents that are approved right now. So omalizumab, it's indicated for refractory CSU. There were 3 studies that got this approved. Really the first two, Asteria 1 and Asteria 2, were the pivotal studies to get it approved. They looked at patients had to have CSU. They were 12 and above. They had to have chronic spontaneous urticaria. They were on an approved dose of an H1 antihistamine, so once daily dosing for, say, loratadine, fexofenadine, or cetirizine, and they were still symptomatic. Both studies, they were kind of run in parallel, same entry criteria. One was a 24-week treatment period. One was a 12-week treatment period. All 3 studies looked at 12 weeks as an efficacy endpoint, so you could compare all the studies together. For the Asteria studies, it was also dose ranging, and they looked at omalizumab 75, 150, and 300 milligrams versus placebo. They all had follow-up. For the Glacial study, these were patients that were more severe. So they had chronic spontaneous urticaria. They were on 4 times the approved second-generation antihistamine plus another controller agent. So that was a leukotriene receptor antagonist, an H2 antagonist, or they were on all 3, still meeting the symptom scores to get into the study. This was a 24-week treatment period, only 2 arms, omalizumab 300 milligrams every 4 weeks, or placebo, also with a 16-week follow-up. So looking at the data, they looked at the Urticaria Activity Score 7 of less than 6, so that's well controlled. And you can look at the Asteria studies on the left side of the slide. They're combined, and you can see that there was a significant improvement or reduction in urticaria activity scores in both the 150 and 300 milligram omalizumab arms compared to placebo. When you look at the Glacial study, there was only the 300 milligram arm and also a significant reduction in urticaria activity scores compared to placebo. When you looked at those who achieved a UAS 7 of 0, they had no itch, no hives, no wheals. You can see about 40% of the patients in the Asteria trials on omalizumab 300 milligrams every 4 weeks achieved this, and about 34% in the Glacial trial, so these were the very severe patients, achieved that UAS 7-0 score compared to placebo. Looking at dupilumab, in their LIBERTY-CSU Cupid studies, it was a 24-week data cut where they looked at this and looked at efficacy. They looked at change in the UAS-7 score and also a change in the itch severity score, the ISS-7 score. So that was the one component of the UAS. They didn't look at the Wheals score. They looked at the itch score. So the top study looked at omalizumab naive patients. So these are individuals, they were ages 6 and older. They had chronic spontaneous urticaria on standard therapy that they continued in the trial and were still symptomatic, but had never been on omalizumab. And you can see there was a significant change, clinically significant change in both the UAS-7 score compared to placebo and the itch severity score 7 compared to placebo. The lower half of the slide looks at individuals who are ages 12 and older who had been on omalizumab and either were intolerant to it or they were incomplete responders to omalizumab, also still symptomatic and on antihistamines. And you can see the change in UAS-7 was not quite as dramatic as those who were omalizumab naive, and the itch severity score also was clinically relevant, but also did not have the same significance as those that were omalizumab naive. So some of these targets for CSU, and like I say, the central role of BTK, which we're now looking at, you can see all the different medications that are out there, some approved, some are still in studies, but you can see where benralizumab's working, where dupilumab works on this slide, omalizumab up at the top, tezepelumab looking at TSLP, and then remibrutinib and the other BTK inhibitor is getting inside the cell, working on that BTK, inhibiting it, which is downstream from all the other targets where everything else is kind of working exterior to the cell. The BTK inhibitors is working on the inside of the cell to prevent mediator release. So looking at the remibrutinib trials, there's 2 trials, REMIX 1 and REMIX 2. They're in phase 3 studies. They were both phase 3 randomized placebo-controlled studies looking at 25 milligrams of remibrutinib twice a day administered orally. It's a pill versus everything else we've been looking at is injectable. There are adult patients who've had CSU, and to get into the study, you had to have it for more than 6 months. So again, CSU is diagnosed 6 weeks or longer, but these patients had to have a stable diagnosis of longer than 6 months, and they were inadequately controlled on second-generation antihistamines. So when you look at the trials, it was randomized 2-to-1, so 2 on remibrutinib versus 1 on placebo. The first 24 weeks of the study was double-blind treatment period, either on remibrutinib or on placebo. After 24 weeks, it was an open-label treatment period. If you were on remibrutinib in the blinded phase, you stayed on it. If you were on placebo, you were started on remibrutinib 25 milligrams twice daily. And you can see the number of patients, it was 300 versus 150. And then there was an open label extension, long-term safety extension. And they had to stay on their background H1 antihistamines throughout the study in both arms. The primary endpoints were change in baseline in the UAS-7 at week 12, and also the change in the itch severity score 7 and the hive severity score 7 at week 12. You can see the secondary endpoints, or the percentage of patients who achieve a UAS-7 of less than 6, so that's well controlled, or a UAS-7 of 0, which is absence of disease at week 12. They also looked at the percentage of patients who had a UAS-7 of less than 6 at 2 weeks, and the occurrence of treatment emergent and serious adverse events in the study. So this is the first 24 weeks of both arms, both studies, REMIX 1 and REMIX 2. The mean change in the UAS-7, you can see a significant drop in the UAS-7 score on the bottom, or the blue line, which is remibrutinib compared to placebo. And you can see that within the first couple of weeks was a dramatic improvement. So there is a very early onset of treatment effect on the remibrutinib on both of these studies. When you look at the change in the baseline UAS-7 score at week 24 in REMIX 1 and REMIX 2, you can see the studies, they looked at the change at week 1, week 12, and week 24, and clinically significant changes, especially at week 12, which is the primary endpoint, and then at week 24 on both arms. But you can also see in this that that week 1 change is quite significant. So again, it gives us some hope that these patients can have early onset of symptom relief. So there's other patient-reported outcomes that were looked at in the REMIX 1 and REMIX 2 studies. So in the sleep and daily activities, so there's in the active arm, the remibrutinib arm versus placebo, there's a reduced impact of CSU on sleep and daily activities versus placebo as early as week 1, and this was sustained all the way through week 52. So there's no kind of getting used to it, and what we call tachyphylaxis is losing its effectiveness as you stay on it throughout the year. There's a complete absence of sleep and activity interference in a greater proportion of patients, 60% on the active arm versus placebo through week 24. And these effects were also maintained throughout week 52, and also in that placebo transitioning to remibrutinib arm also. So they saw that same relief from week 24 going through week 52. There was an improvement in the symptoms of itch and hives observed at as early as week 1 and sustained also through week 52 in the patients who were on remibrutinib from the beginning. And again, similar at week 52, there's a similar proportion of patients in the remibrutinib arms and the placebo transition remibrutinib arms that had a complete absence of itch and hives. So again, complete control of their disease. Looking at the safety, really no significant issue when you look at this, remibrutinib in the middle and placebo on the right. Again, it was a 2-to-1 enrollment, so there's more remibrutinib patients. But if you look at the percentage of patients with those adverse events, about 64% had at least one adverse event. Serious adverse events were around 2 to 3% of those. Serious infection was no difference between the two treatment arms. AE's leading treatment discontinuation was similar between both placebo and active treatment. And when you look at the adverse events affecting 3% or more of the patients, these studies were done during the pandemic, so that's why you see the largest adverse event being COVID infections, but you can see nasopharyngitis, headache, petechiae. The biggest difference between the two is you will look at petechiae. There's about nearly 4% of the remibrutinib patients develop petechiae. This typically was on their lower extremities. Versus 0.3%. This is something that resolved over time, was non-symptomatic, and saw no other associated symptoms with the petechiae. Looking at the other BTK inhibitor, this is a randomized placebo-controlled dose-finding study. It's administered orally. You can see we're looking at just the double-blind treatment period, really for today's presentation. Three different treatment arms. They're looking at 1,200 milligrams a day, 800 milligrams a day, and 400 milligrams a day compared to placebo. And going forward in the open label, they're looking at just 1,200 milligrams a day of this product. You can see the primary endpoints, again, change from baseline in the Urticaria activity score at week 12. Secondary endpoints are the weekly change in baseline in the weekly itch severity score, the weekly hive severity score, and also the UAS7 at 4 weeks, and the proportion of patients who develop a UAS7 score less than 6 at 12 weeks, and also those that have a UAS7 score of 0 at 12 weeks, along with looking at safety and biomarkers. And you can see on the right-hand part of the slide, different biomarkers they're looking at in the study. Total IgE, total serum IgG levels, also eosinophil levels, and some other markers of autoimmunity. Looking at their initial data points, so their UAS7 score was clinically significant for the 1,200 milligram dose compared to the 800, 400 milligram dose and placebo. So that's why in that extension, they're going with 1,200 milligrams. Also, the itch severity score, you see a similar response, again, clinically significant at the 1,200 milligram dose. In the itch severity score 7 change compared to the 800, 400 milligram and placebo dose. Is well tolerated. The most common TEA so far that they've seen is headache, nausea, and diarrhea. Again, these are phase 2 studies. So we really want to look at improving the quality of life in CSU. So it's really a comprehensive multidisciplinary approach. I mean, these patients will see a multitude of physicians depending on what's going on. So again, going back to John, our 35-year-old, after several weeks, he's still not experiencing much relief with his CSU symptoms, despite trials of, again, diphenhydramine every 4 to 6 hours, loratadine 10 milligrams daily, fexofenadine 180 milligrams once daily. What would your next steps be? Right now, our options are looking at omalizumab, potentially dupilumab, which is a new option for us. And if those aren't working, we would then look at cyclosporin. Would John be a candidate for BTK inhibition therapies if they become available? Well, looking at the old data or the data that's been presented so far, absolutely. I think any CSU patient, if we get a BTK inhibitor that is approved, would be a candidate for that. So, kind of some of the questions. We want a personalized treatment for all these patients. So how would you navigate treatment to minimize daytime sleepiness to help John's alertness during work? One, you want to get away from a sedating antihistamine like diphenhydramine. You also want to help him start sleeping at night. So you need better disease control, because the more he's sleep deprived, the less he's going to be alert during the day. How would you discuss evidence for advanced and emerging treatment options for CSU with John? And I think we're doing this at this point, saying, there are new medications that are in study. Whether they get approved or not, we don't know. That's still to be determined. But there's active research in the CSU space. So if nothing else, it gives these patients hope who may be struggling, and even struggling if they're now on omalizumab and still not having a complete response. Who are some of the key players we want on a healthcare team to help engage in John's care? So one, an allergist, immunologist, or dermatologist. I mean, if there's any question, is this true CSU? Is this an urticarial vasculitis? Are we confused? We do want a biopsy, so we want a dermatologist involved. We want primary care to be involved, and also pharmacy and maybe others, that mental health professionals if we need to. So when we look at the management decisions and treatment adjustments for CSU, there's kind of this, assess the situation at the top of the loop. Are there diagnostic procedures to do? Have we done them? Are there other comorbidities we need to consider? What's the severity of their hives? Do you want to do a UAS 7 in the office, which you can easily do? What are other patient-reported outcomes that you can measure? What's some of the patient's preferences when we talk about, disease medication treatment, disease therapies that we can come up with? What are some of the adverse events to treatment they may be having or had in the past? We want to look at that, modify our treatment response. We want to act on the information we see, right? We don't want to just say, well, it's highs, we want to put up with it. Modify the treatment, looking at other treatment of comorbidities that may have an impact on their CSU. Look at other non-pharmacologic interventions, especially if they've got inducible urticaria. Try to avoid those triggers, right? And we want to work on educating the patient. And then again, you want to continue to adjust what they're doing. If they're inadequately controlled, step up. If they're on a single daily dose of a second-generation antihistamine, rapidly step up to 2 times to 4 times daily dosing. If that's not working, we got to move on and look at the biologics that are available for these patients at that point. If they're doing really well, we want to step down. So looking at the bottom part of the slide, you can look at the urticaria control test, and there's a test out there. If the score is less than 12, they're very they're very poorly controlled. They're uncontrolled. We want to step up, do other things at that point. And you can see, kicking up the second generation antihistamine, starting them on omalizumab if they're not on it. If they're well controlled, you continue the therapy, try to optimize it to that point to continue to follow them. If they're completely controlled, you want to step down. So completely controlled, they're not itching, they're not having hives, right? If they're less than that, you may not want to step back because I think they have a great chance of breaking through. And these patients will tell you if they feel like they could even step down on therapy. They'll tell you, I can tell when my omalizumab dose is due. I start itching, I start breaking out, and I get it, and it kind of goes away. It's not a good time to think about stepping down therapy on that individual. Or, if I miss 1 dose of my second-generation antihistamine, I start itching and breaking through. So there's, kind of 5 charters or 5 principles that I think patients deserve, and they should be able to ask and say, hey, these are the things I want. And this is really what it looks at. And it's a patient saying, I deserve an accurate and timely diagnosis of my chronic urticaria. So we want to listen to them. We want to believe them and make them feel heard. And I think a lot of them don't feel heard. I deserve access to specialty care. So if they're not getting somewhere with a primary care physician or another practitioner, I think they need to be able to be referred on to get to a better diagnosis. I deserve access to innovative treatments that reduce the burden of CU, chronic urticaria, on my daily life. So if, traditional, second-generation antihistamines are not working, we need to get up to better therapies for these individuals. I deserve to be free of unnecessary treatment-related side effects during the management of chronic urticaria. This could be the side effects of a biologic. It could be the side effects of a first-generation antihistamine. It could be the side effects of cyclosporin if we've moved on beyond that. So we want to listen and see what's going on. We don't want to fix a problem, at the expense of creating side effects and untoward effects that the patient doesn't want. And I really expect a holistic treatment approach to address all the components of my life impacted by chronic urticaria. So we want to listen to them. How's it affecting their life? Social, work, sexual health, etc., sleep. We want to make sure that we listen to them and address those and make them, again, feel heard. And they'll, we need to be a part of their team, and they need to be a part of our team. So we talk about shared decision-making, and I've always been a big proponent of this long before the term shared decision-making came about. But patients need to be informed about what the treatment options are. I like to lay it out for them and kind of say, what's the good and bad of this? High-dose antihistamines, what can go wrong, or what are the potential side effects with that? If I'm looking at omalizumab, what does the label indication say, and explain some of the side effects? Or if I'm even looking at cyclosporin, what are some of the, risk and benefits for that so they can make an informed decision. We want to know what their goals are. So they need to say, hey, we want to involve them and say, okay, what's your goal of treatment here? We want you to be part of this. What is it you're looking to solve? Is it to get to sleep? Is it to not have hives going into a meeting, etc.? And look at all aspects of that so we can address those needs that they're looking at. Looking at patient-reported outcomes, whether you're measuring it with a tool in the office or you're just asking them, are you sleeping at night? What are you not doing because of your hives? Do you not take a shower? Do you not go to the gym anymore because if you work out, you start breaking out? We want to be able to control that. And also consider patient-specific barriers to treatment and adherence, whether it's cost, side effects. We want to engage them and listen to them about what's going on and try to solve those dilemmas for the patient. So again, it's a multidisciplinary care for CSU. We want to look at their atopic disease. Do they have other atopic issues, asthma, allergic rhinitis, food allergies, eczema, atopic dermatitis? Are there psychological, mental health issues that they're dealing with, whether it's because they're sleep deprived, whether this has led them and worsened or caused depression? This is a very impactful disease that they're dealing with. Are there other autoimmune conditions which we want to look at? So you can see on the right-hand part of the slide, other providers to kind of loop into this and help manage these patients. So in conclusions, looking back, 40 to 50% of patients with chronic hives respond to high-dose antihistamines. It means, 50 to 60% do not. They need other treatment options. Biologics have opened up the field to urticaria and provide some additional treatment options. So moving on from antihistamines, we want to look at the biologics that are approved at this point. Looking at research, BTK inhibitors have the potential to become a novel oral treatment, not injectable. Options for patients that may address unmet needs who have CSU that are inadequately controlled on second-generation antihistamines and specifically inadequately controlled on the approved biologics at this point. It's a challenge to define specific phenotypes, and we want to try to figure out who's going to respond and not to a specific treatment modality. So if we can help with some of those endotypes and point-of-care biomarkers, if we can start measuring those in our office, starting to look at total IgE levels, which I didn't, measure before because there wasn't a reason to, but now there's a good reason to look at some of these biomarkers to help us decide on therapeutic decisions in our CSU patients. So that really kind of brings us to the close of our discussion today. I hope you found it informative and useful in your practice, and encourage you to access the supplemental program materials. Thank you very much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by the University of Cincinnati. This activity is developed in collaboration with our educational partner, PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. To access all materials for this activity, visit peerview.com/DNY860.